Hi guys. Now we're going on to bowel obstruction. I think this is just part of your final, so I don't think you've had a test over this yet, from what I know. Um, so what is a bowel obstruction? So it can be basically the terminology is like something that obstructs your bowel. So she has a little picture here and then the little like definition kind of thing over here about just what the GI tract does, which we should all know by now. And then just telling you like it's 25 feet long, stuff like that. So you can have diverticulitis, tumors. It can be mechanical and non-mechanical, or things that I wrote down next to it for examples that she gave us. So it goes into small intestine and large intestine. And so your small intestine is very long. It's 16 to 19 feet. There's the three parts: duodenum, jejunum, and ileum. And then surface area, there's like the villi. So many things are reabsorbed in this area. So this is really important for things to get reabsorbed here. And then there's movement, digestion, and absorption. So then your large intestine is shorter, but it's bigger. So that is only 5 to 6 feet. And then it's got the ascending, transverse, descending, sigmoid, and then, the end result. Functions, it moves, it absorbs only water and electrolytes. So your small intestine does most of the absorbing. Whatever is left that goes on to the large intestine, it's water and electrolytes that gets reabsorbed there. And then elimination. So then she's got a picture here just of your basic anatomy. And it's really not that important. So your labs that go along with this. So you'll look at your CBC, your liver goes along with this, your pancreas goes along with this. You have different electrolytes. So with your liver, we'll go back a little bit. You want to get that PT time because that has everything to do with your clotting function. The rate that it converts to thrombin, and then if it's vitamin K dependent, because clotting, vitamin K, liver, they all go together. Enzymes, your AST and your ALT, bilirubin, ammonia, electrolytes, absorption, reabsorption, malabsorption of your electrolytes, and then if you have like vomiting, diarrhea, NG suction, this will all contribute of how much you actually have to reabsorb. If you are puking a lot, you're not going to get anything to your small intestine. If you're having excessive diarrhea, it's going there through there too quickly. You're not getting it. If you're suctioning them out, like NG suction all the time, they're not going to get anything to their small intestine either. So just like malabsorption, like the cause of malabsorption. Pancreas, your enzymes. Then you can do stool tests. C. diff. If you smelt it, you can't forget it. And then different urine tests. So there's two different kinds of intestinal obstructions. So there's mechanical and non-mechanical. So we'll start with mechanical, and that's just a physical block. There is something, whether it's stool or like a twisting, like it's mechanically blocking elimination through the whole GI tract. So it can be outside. So a lot of people who have endometriosis, my mom had endometriosis, and it does the opposite of what it's supposed to do. Instead of blood coming out, it goes back up, and then it makes all your intestines stick together. So adhesion of those from the outside of your bowel can cause an obstruction. Crohn's disease, you can have different tumors. There's like volvulos. I can't say it right, but it's the twisting. There's a lot of VOVLV. I just think whenever I see that word, I just think of twisting. And then you can have different folds and diverticulitis. There's a lot of things that can cause mechanical. Non-mechanical is, okay, so she'll ask you these questions, like the paralytic ileus. Know what these are. She will ask questions about them. That is the decreased or absent result of a neuromuscular disturbance. So like if you opioids is one of them, like if they give you analgesics, if you go in for surgery, especially if your surgery is in that area, it will like the interaction within your body, it's a side effect. It will make you not go to the bathroom. And it's not mechanical. It's not like twisting or adhering or a block. It's a side effect of the drug that you're taking. Post-op ileus, this is like same thing like I just said. electrical disturbances. Sometimes if you have, they say like, oh, take a lot of vitamin, whatever, and it'll help you go to the bathroom. If you don't have enough of that vitamin, just electrolyte disturbances in general. There's peritonitis. No, there's no L in that word. It's right here in your notes. I'm not sure if you can see it. Right there. But that's a cause. I don't remember seeing that on the test, but I know paralytic ileus is on there. Vascular insufficiency, so decreased blood flow, can also decrease your movement. So pathophysiology, that is the intestinal content. I don't really need to read you. It goes from you ingest it, it goes down to your stomach, you break it all down with all your enzymes in your tummy. It either goes into your small intestine, not either, it goes into your small intestine. Things like your body will sense, does she need more calcium? Does she need more vitamin this or vitamin that? And it'll absorb what you need, fluid and electrolytes as well. And then in your large intestine, it's only fluid and electrolytes. And then elimination happens. What is the issue is when either mechanical or non-mechanical happens and that system doesn't go correctly. Usually, like I said, NG vomiting, NG suctioning, vomiting, diarrhea, those things aren't necessarily mechanical or non-mechanical. Those are just things that can cause malabsorption to begin with. But what happens with the mechanical and non-mechanical is that it usually gets to, you eat it, it goes to your tummy, and it gets into at least your small intestine. Now, depending on where the block is, which we'll talk about later, that's what's going to be your side effects or what you're going to see as clinical manifestations. So you increase peristalsis to compensate. So you're going to feel like not so good. Your tummy's going to be moving all around because it's trying to compensate. Eventually, it's not going to try and compensate anymore because nothing can be done about it. And that increases your stimulus and secretions, and then increases you trying to go to the bathroom. But then once it becomes more worse, increased capillary permeability, and then the plasma will leak into your peritoneal cavity. It doesn't even sound good. Fluid is trapped in the intestines, decreased absorption of fluid and electrolytes, and then hypovolemia, because it's pooling, like you're having fluid pool in your tummy, and then you're not going to have fluid come back to your heart, so it's going to be hypovolemic, and then also electrolyte imbalances. So then she has pictures down here. So sometimes you can have things stick to your bowel on the outside. If you have surgery, some of those like scarring or tissues can also stick stuff like that together. And then you can have like colon cancer, just tumors, different things grow. There's a lot of different things. But then it will back up the intestine. So eventually you won't be able to get anything past the blockage. And then if it's large, the intestines will be caused by diverticulitum. But basically just know it's just going to keep backing up. Is the patient at risk for okay, sorry, I had to read it. So whether you're at risk for metabolic acidosis or alkalosis depends on where your block is. So it says in the small intestine, like high in the small, like duodenum, the first part of the small intestine, you're at risk for losing acid. If you're losing acid, you're alkalotic, right? Because you're losing acid because if the blockage is right where your stomach meets the small intestine, you can't fit anything else through the block. It's blocked. So you're going to either puke it up or it's going to go to the small intestine and then come back up as somewhat digested food. It'll smell very bad. But if you're puking all that acid up because it won't go the other way down, then you're going to be alkalotic. You're getting rid of your acid. pH in your stomach is acidotic. You're getting rid of it. You're alkalotic. And if it's like lower down, you're going to be acidotic. So if it's lower down, you get to the point where in your block, things can't go through. But on this, you're going to lose it all. You're going to lose everything that you have to lose after the block. And that's getting rid of all of your base. So then you're going to become alkalotic. How does hypovolemia cause? Okay, so bacteria are in your bowel, right? So if blood flow to your bowel is decreased, it's going to cause peritonitis, an inflammation of your bowel, pretty much. So it's not moving. So if you have decreased fluids help your bowel move. If you drink a lot of water, it'll help you go to the bathroom, people say. If you have decreased fluids, if you're hypovolemic, whether you have decreased fluids in like your oral, GI system, or even just like decreased perfusion of blood to your digestional tract, if you don't have the blood flow, peristalsis isn't going to happen. So hypovolemic can make it not move. And then also your bacteria, I know this sounds really weird. I'm not sure if you've talked about it yet in fourth semester. I forget where we learned it, but I think we learned it in fifth. I'm not sure. But translocation, so you have bacteria in your stomach, and if peristalsis isn't happening, you can have that bacteria translocate, and it can go other places and cause bacterial infections. I don't think she has it here. It just says, compromised blood flow, but that is something later on that you could see. So most common mechanical bowel obstruction is in the small intestine. And then most common causes of the obstruction in 65 years or older is like decreased mobility, decreased peristalsis, nutrition, and like fiber and water. And then types of mechanical obstructions. She has here two different pictures. I'm not sure if you can see them. One is the twisting, like we talked about. And that also decreases blood supply because you have blood flow running. Like here's my bowel. You have it running this way. So if you twist it, you're not going to get it. You're not going to get it to where it needs to go. It's also very painful. So you were supposed to work in groups and do some of these. And so we did them in class and we wrote them all this way. I'm not sure if she told you to look them up on your own or not, but I will tell you what we came up with in our class. So detailed assessment. So think what's normal. So we did, when someone first comes in and they're complaining like, oh, my tummy hurts, what are you always going to ask? Diet? What have you eaten lately? Or what is your normal diet? Or when's the last time you consumed something? What was it? History. Have you had this before? Have you had, any issues, any family history? Surgery. Have you been in surgery? Scar tissue. When was your last bowel movement? What did it look like? Constipation, duration, nausea, vomiting, stuff like that. Do you have a disease process that this is common with? Like you'll get a cystic fibrosis kid that comes in and their bowel is not normal. They have extra secretions, if you know what I mean. So it's not normal. And then physical assessment. So you're going to inspect and then listen, auscultate, and then percuss, and then palpate. Those are the orders that, we assess our abdomen in. And then in the beginning, it'll be hyperresonance. So, or hyperactive bowel sounds. So when you listen, you'll hear lots of moving going on. You're like, oh, they're fine. But then towards the later end, it's going to be hypo because in the beginning, they're trying to compensate. So you're going to hear all this movement because they're trying to compensate for it. Towards the end, it's more a severe case. Nothing's really getting through that blockage. Depending on where it is, you're not going to hear anything. Look at their fever. This is still physical assessment. Fever, vital signs, mucosa, hydration. When you palpate, what do you feel? I mean, you're going to hear stuff, and I just told you like hyperresonance or hyperactive bowel sounds or hypoactive bowel sounds, but what do you feel? Sometimes you can feel poop sitting in there. Get a CT, get an X-ray, see if there's anything that you can see on those. So clinical manifestations for small. So we came up with discomfort, pain, and then peristalsis in waves, and the pain is intermittent. So I think there was a difference somewhere in here we found a difference between small intestine and large intestine that our class talked about, but the discomfort is intermittent, and the upper region is distended. Peristalsis comes and goes in waves. Nausea, vomiting of stool, because if there's a block, it's going to go the other way to get out. Obstipation. It is severe constipation and no gas. That's what we came up with in our group. And then severe fluid and electrolyte imbalances and alkalosis. So that's upper, because remember, we're getting rid of all our acid by puking it back up, so we're going to be alkalotic. Now, in the colon and large intestine, you're going to see intermittent pain, but it's going to be lower. And then you're not going to vomit because you're going to get it low enough where it's not going to come, it can't go 15 feet back up your small intestine and puke it out. If that happened, oh my goodness. But no, you're not going to puke. It's ribbony like stool because it's trying to get through. Like maybe even just a little bit can get through that blockage. It's going to be like ribbony, loose. There's going to be no fluid and electrolyte imbalances because it can get through your small intestine. And your small intestine is what absorbs your fluid and electrolytes. You're going to be acidotic because you're getting rid of all your alkalosis, getting rid of all your base, so you're going to be acidotic. And then boroborgamy is the term that we found also for the large intestine. So clinical manifestations of non-mechanical. This is like those Percocet takers after surgery, and you could also, like, they just got out of surgery and they could still have anesthetic in their system, just a lot of things. So it's not physical, but there is a constant pain. So mechanical in those two, intermittent pain or discomfort. With clinical, with clinical manifestations of non-mechanical, it's going to be constant pain. Their bellies are going to be distended, decreased bowel sounds, and then absent later. Vomiting, it could be gastric content, or, if it got lower down, then it comes back up. It would have a foul odor. And then obstipation again. And then also we have cause, electrolyte, fluid and electrolytes, post-op, opioids, and pancreatitis could all cause these non-mechanical ones as well. So non-surgical interventions, put them on NPO. If you know that they're going to puke it back up later, don't give it to them. They might need an NG tube. You can try enemas to try and really get that stool out. Give them IV fluids. You can give like medications to help with these things. But we have GI or digestive functions from opioids, if that's what it's from. Then take them off the opioid. I mean, I know that they're going to be in pain, but maybe try and see if you can do other interventions to get them off of those opioids sooner than later. And then you could also do oral care because they're still going to need their teeth brushed. Ice chips sometimes is a good idea. You can get, I know they're going to, okay, so they're in a lot of pain, right? If it's caused by opioids and they're in a lot of pain, we give opioids for pain. So I know it can be difficult to think it through, but I mean, if it's caused by opioids, try and get them on something that's not that. Or sometimes, like after my surgery, they gave me opioids, but they were like, take a stool softener because this is always a side effect. So just think it through logically. You're nurses, you have this. Consult other people to help you as well. Positioning, left sideline is apparently comfortable. Increased mobility. Sometimes people don't poop because they don't walk. Like if I lay in bed all day long and I don't get up and walk, like of course things aren't going to want to move the way they're supposed to. Increase fiber as well in their diet, but if they're MPO, I get that you can't increase fiber, but if you can increase fiber, if that's an option, do it. Okay, so surgical interventions. So we came up with a bowel resection, a colonoscopy. No, not a colonoscopy. What am I talking about? Colostomy. Okay, colostomy, ileostomy. They can do like a stent if the blockage is there. If it's a tumor that's like pressing on things, they can put a stent in there. And always make sure your patients are passing gas. Like if they're not passing gas, that's 100% bowel obstruction. If they're kind of passing gas, kind of not passing gas, but still doing something, peristalsis is kind of working and it's not a complete obstruction. And then it says an obstruction caused by a tumor or diverticulitis. The colon is resected and may be primary colonostomy. So, or colostomy. I don't know why I can't say that word today. What that says is like they can temporarily cut that bowel and put it out and give you a colostomy bag, and then they can always reattach that bowel together as long as the bowel, so that blood flow is still healthy and they think that it's reattachable. So post-op care, Um, NG until peristalsis returns. Um, it's low intermittent suctioning. It's never constant because if you constantly suck that acid out of their stomach, they're going to become alkalotic, and then you got a whole nother issue on your hands. A liquid diet at first. If they have nausea and vomiting, discontinue, you can always go back to it. If they tolerate it well, thick liquids, stuff like that. And then finally to their regular diet. When a patient is passing gas and has bowel sounds for an extended period of time and no nausea and vomiting, you can remove the NG and put them back on and start them with a clear liquid diet. So answer the clinical judgment question. I don't know if you did this, but we did. I don't know what the question was. I just have written down elderly, exercise, normal bowel movement, medications, and fiber. I feel like it was about some type of an elderly patient, and they needed to exercise more. They needed to get on a regimen of medications and also eat more fiber, maybe to increase their peristalsis and go to the bathroom. That's the best that I can come up with. I'm not sure what it actually said. Home management. So you can be hospitalized and monitored and treated, but then if you are feeling better and the treatment is working, they'll send you home. So discuss educational needs for home or required to go home. So again, we have oral care, hydrate, fiber, and nutrition. So oral care is super important because you don't want that bacteria that's in your mouth and GI to locate anywhere else. So make sure you're still making the gut move and brushing their teeth, hydrate them, give them fiber. Good idea. So my next one, so we have fecal impassion. We have two different things. I'll just read them off. So mechanical adhesions, a tumor, fecal impaction, hernia, GI. And then I have high Fowlers. Set them forward, check their pH, tape their NG at the nose. That way you know where it was. And then also tape it to the gown and then the bed. That way it doesn't get ripped out somehow. Intermittent suction on low, underlying low. And then we have failure to pass gas, complete obstruction, report immediately. If pain changes from chronic discomfort or chronic discomfort to constant, the change from, because sometimes you can have oh, I'm hurt. No, it doesn't. Yes, it does. No, it doesn't. Intermittent. And then if it's constant, there's something wrong all the time. There's something wrong, but you know what I mean? It becomes more in danger. And that's all I have for bowel obstruction. But again, just like the other two, think about what the bowel does. We all went through anatomy. I know a lot of people are like a jejunum, but duodenum, jejunum, ileum, 3 parts of your small intestine. You got all your large intestine, ascending, transverse, descending, sigmoid. The small intestine absorbs most of all of our things that we need to absorb. The large intestine does fluid and electrolytes. So think if you have a blockage in your small intestine up higher, you're not going to get that food to go into any other part of your small intestine or large intestine. So you're probably going to have fluid electrolyte imbalances. But if you get it to that large intestine, it's gone through the small intestine, which means you don't have any fluid or electrolyte imbalances because you've gotten it that far. Mechanical versus non-mechanical, where the mechanical obstruction could be. Why is this happening? Is it because they have decreased mobility? Are they taking opioids? Were they on analgesics? Is this common for their disease process of what they have? How is it affecting them? What signs and symptoms do they have? And through their signs and symptoms, you should be able to say it's a mechanical in their small intestine, or it's all over, it's constant, it's non-mechanical from the opioids they're taking. And then once you figure out what it is, how are you going to treat it? I know sometimes they'll put an NG down and kind of suck some stuff out, put them on NPO. How are you going to treat it? And then what are nursing interventions you can do? Kind of like I just said, high Fowlers, you can put them in high Fowlers. You can try and give them certain medications to help. Maybe stool softeners if it's an option. But again, if you guys have any questions, I'm here. I'm sorry that the other two are kind of late. But I hope my SLA for all of the semester has been helpful at some point. And I'm hopeful for you guys that 5th semester goes well for you too. Um, this is my last SLA. I'm graduating. Yay! I'm gonna be in the NICU, so I'm super excited, and then I'll be cross-trained into PICU too. But if you guys ever need anything, even if it's non-nursing related, you just need someone to tell you you're doing a good job. You're doing a good job. I'm proud of you. Okay, have a great day. Bye.